Good afternoon. My name is Carolee Lee, and I'm the founder and CEO of WHAM, Women's Health Access Matters, a 501c3 created in response to the considerable funding gap, historical exclusion, and underrepresentation of women in health research. Women have been historically left out of medical research, even for diseases that differentially and disproportionately impact them, such as lung cancer. This medical research gender gap is a major obstacle to not only achieving equity in healthcare, but to advancing the health and well-being of women around the world and a healthier society. But let's look at some relevant data. Women are the majority of the US population, more than 50% of the workforce, and control over 60% of the personal wealth. In the US, women are responsible for over 85% of consumer spending and make over 80% of healthcare decisions. Until now, we have lacked data about the economic costs, benefits, and social impacts of attention to sex and gender in health research. The medical research gender gap is a major obstacle to not only achieving equity in healthcare, but to advancing the health and well-being of women and societies around the world as women globally drive the economy. Surprisingly, no one had evaluated the economic consequences of the status quo, the costs we incur, the benefits we leave on the table when research under-includes women. In 2019, I brought together a group of businesswomen and set out to change this scenario. And we created WHAM to catalyze accelerated research and investment and focused on creating the WHAM report with the intention to build the business case for funding research focused on women by asking, what are the economic impacts of increasing investment in women's health research? We commissioned the RAND Corporation to begin a rigorous focused study to quantify costs and socioeconomic benefits of increased research funding focused on women. And we chose 4 areas to study, which we knew disproportionately, exclusively, or differentially affected women: brain health, heart health, autoimmune, immune disease, and cancer. Just consider how those differences manifest in health outcomes. Here are some of the findings from our report. Alzheimer's disease costs our economy $305 billion in 2020, and women are 66% of patients, yet only 12% of research dollars focus specifically on women. Cardiac artery disease costs our economy over $555 billion a year and is the #1 killer of women, yet only 4.5% of research dollars focus specifically on women. Autoimmune rheumatoid arthritis costs the US economy over $40 billion a year. Women are 70% of patients, yet only 7% of research dollars focus specifically on women. Lung cancer costs our economy over $23 billion a year and is the #1 cause of cancer deaths in women, yet only 15% of research dollars focus specifically on women. In each of these examples, we still don't know why women are affected disproportionately, as there just isn't enough information or data or research, and it isn't because women live longer. It turns out women's health research isn't just good science, it's a good investment, and it yields far higher return rates than general research. The WHAM report finds a higher rate of return for research focused on women, driving billions of dollars to the economy through greater quality of life, workforce and economic gains, and reduced healthcare costs. According to RAND's models, a very small investment yields a significant return. Investing $350 million across just 4 diseases would generate $14 billion in economic returns. Based on this data, a resolution has been presented to Congress to increase funding for women's research. Today, we're focused on offering you the most cogent data and the future for lung cancer. Lung cancer is the #1 cause of cancer deaths in women, more than breast, ovarian, and cervical cancers combined. And non-smoking women are more than 2 times as likely to get lung cancer than non-smoking men. Yet lung cancer research receives the least amount of funding of the major cancers affecting women. Of the NIH's 2019 $267 million lung cancer budget, only 15% went to women, focused research equating to nearly $7 per man and just $1 per woman. WHAM's new data shows that investing in women's lung cancer research will generate millions in economic benefits, save countless lives, and lead to substantial gains and improved quality of life. This data is a catalyst for change to improve the health of women, advance the future of medicine, and specifically of precision medicine, and strengthen our economy and our workforce. Lung cancer has become the leading cause of death cancer in women, as I said, and also globally, with prevalence among women specifically highest in the US, followed by the UK and Japan. How could we possibly have precision medicine for men and women if we're not studying both sexes equally? To look carefully at these issues, we've assembled leaders in this field who will offer their insights and expertise at this roundtable discussion. And first, I'm delighted to introduce Laurie Fenton, co-founder, president, and CEO of Go-To for Lung Cancer, and our esteemed partner in the WHAM report on lung cancer. We are greatly appreciative of your support, Laurie, and thank you so much.
My goodness, Carol, and to the WHAM group, to be a part of thought leaders, but doers. And this particular panel, it's music to our ears because this has been a focus of ours for decades, and that is the unique impact lung cancer has on women. And to bring the type of data points that you shared, not just about the health benefits, but the economic benefits that an investment in women's research for lung cancer and the other diseases that you presented, it would have just an impact that is so significant in magnitudes that's hard to realize. What we know is that lung cancer does impact women differently than men. We know that there are so many facets of the disease, including risk factors, clinical characteristics, progression, time to survival, that differ between men and women. And while there's a limited amount of research that points to genetic, behavioral, environmental, even hormonal differences, as you pointed out, Carol, clearly there has been insufficient work to understand this and then adapt research and then ultimately care pathways appropriately. So what you and WHAM have done, and we are so grateful to be partnering with, is to continue to elevate the awareness around the public health imperative that this disease is for women, and then to bring together science, business leaders, public health interests, advocacy organizations, researchers, to demand improvements and change that will bring not just better outcomes from a health standpoint, but for an economic standpoint. We have long advanced Women and Lung Cancer Research and Preventive Service Act that is again in this Congress that we're hoping this conversation can bring heightened emphasis on the need to move it forward so that we can begin addressing in an accelerated way the needs of women who are impacted by this disease. So brava to WHAM and to all of the women that are on this roundtable that are speaking to this public health imperative today and in the days and weeks ahead.
It has been such a pleasure to work with you and partner with you, and we're extremely grateful to have that opportunity. Now I'd like to welcome Dr. Julie Brahmer of Johns Hopkins Medicine, where she's director of the Thoracic Oncology Program, director of the Upper Aerodigestive Disease Program in the Bloomberg Kimmel Institute for Cancer Immunotherapy, and professor of oncology. And Julie, I would love to ask you a few questions. You and I have had some wonderful conversation. From your perspective as a lung cancer specialist, as an oncologist, how does lung cancer present in women, and why is it such a different disease? Why are non-smoking women more likely than non-smoking men, for example, to get lung cancer? Can you help us understand that?
Well, I think in order to understand that, we have looked at whether or not women can repair their DNA when they're exposed to certain things. So that may be some of it, that women's bodies don't repair the DNA damage that occurs on different exposures. There also may be differences in how each sex, their immune system actually surveils for cancer or foreignness in order to be able to control. So there is a yin and yang about how our immune system monitors for abnormal cells. And so there may be sex differences in that as well. So I do think it's important to look at these factors to try to really understand why, particularly in never smoking women, why this is so compared to never smoking men. Since we are seeing increased occurrence of lung cancer in these groups. And this group is not someone that we would typically even consider lung cancer screening.
And so share a little bit with us why is there, it appears, not a tremendous amount of early detection and annual testing like we have for breast cancer?
Exactly. Well, a lot of it is awareness, both from a physician standpoint as well as from a patient standpoint. They're just not aware that CAT scans are approved for lung cancer screening, but only in those patients who are at highest risk, older patients above the age of 50, and either patients with a lot of smoking history, that they've smoked in the past, but a fair amount, or patients that are current smokers above the age of 50. That still does not, even those patients are not aware unless a physician brings that up. There also are a lot of issues with uptake. Even if you know that you need to be screened, there's a lot of things that a doctor has to go through in order to get the CAT scan actually approved to be done. And then also just ease of access. It certainly would be great to have a blood test to be able to do this. I think the uptake would be better. But I do think there is a large patient population where we don't have great screening methods for, particularly those folks that are never smokers. And how are we able to model risk in that patient population? We do think there is something to do with family history. So if you have a family history of lung cancer, then you're at higher risk for developing that. And there are screening programs that are looking at that, but that's more on a research side.
But Julie, you're talking about I don't know exactly how large a group that have high risk criteria, but should the risk criteria be expanded for those eligible to be screened? In other words, shouldn't it be larger than perhaps if you smoked? And is it true that only 40% of lung cancer patients get the full panel of testing?
Yes. So, for screening, the biggest issue is that the patients who are eligible aren't even being made aware that they should do that. But we do think that the group that should be screened needs to expand, thus trying to figure out, what makes someone who is a never smoker more predisposed to developing lung cancer compared to even someone who is a heavy smoker and never develops lung cancer. So how can we figure that out? And I think that gets to both sex differences as well as DNA differences, something that's inherent genetically in each patient.
Mm-hmm.
I do think, trying to improve our screening platforms, I think will also help this as well.
I know that you're very involved in immunotherapy, and immunotherapy has become one of the greatest impacts and has one of the greatest impacts on lung cancer survival. Talk to us a little bit about the research that you're doing and actually the practicing that you're doing of immunotherapy.
Yes, so immunotherapy is completely different than chemotherapy. So immunotherapy is trying to harness your own immune system to attack the cancer. And this has been approved for use in patients with metastatic disease, so advanced disease, but now is also being used around the time of surgery, either beforehand or after, to try to prevent your cancer from coming back. So I think immunotherapy also the pros of immunotherapy is that even when you stop the therapy, if you've had control of your cancer with this, you can see your immune system being taught to continue to watch for cancer cells occurring and hopefully prevent the cancer from recurring in each patient's situation. Obviously, we have a lot of ways to go in order to help each patient benefit from this. And so I think being able to personalize this type of therapy for each patient is important. Now, this is different compared to targeted therapies. Targeted therapies were developed to hit or target a specific change, typically a gene change, where these type of therapies have a great response, but patients have to remain on this type of treatment in order to keep their cancer under control. So it's a great personalization of medicine and definitely different from chemotherapy as well. But I do think from a genomics testing, so looking at each patient's cancer to be able to detect this change does not occur enough. And so again, trying to empower each patient to say, did you test my cancer for these gene changes, that a pill might be appropriate or even more appropriate than immunotherapy, is important to ask, because we do know that not enough patients are getting this testing done. And there's a lot of factors on that. Sometimes it's just having enough cancer cells to do the test. But a lot of times it's just not knowing enough that each of these patients' cancers need to be tested.
Well, I could ask you another 10 questions, but I'm going to go on to our next panelist, and then we're going to all have an opportunity to talk together. So thank you so much for enlightening us in the wonderful work that you're doing. Anne-Renee Hartman is the co-founder and chief medical officer at Adela, where they are focused on the detection of cancer and other high morbidity, high mortality conditions through a blood test, a breakthrough approach to early detection. And I'm fascinated, Anne-Renee, because obviously moving from what we were just talking about in terms of early detection to the kind of work that you and your company are doing could be a game changer. Could you tell us a little bit? First of all, I'm very curious about how you started this company, and tell me exactly what you're trying to achieve.
Yes, thank you so much, Carolee. So I've been working in the liquid biopsy space and the application of liquid biopsy technologies for early cancer detection for the past 7 or so years. The whole space of what we're calling liquid biopsy early detection came about very interestingly through a large registrational study of pregnant women. And these women were undergoing non-invasive prenatal testing. And through this large study of roughly 125,000 women, several women, 12 to be exact, had signals in the blood that looked aberrant and were not coming from the fetus. So non-invasive prenatal testing is looking at fetal chromosomal anomalies in the blood. And for all the world, it looked like cancer. And interestingly, the woman that identified this was currently the lab director at Illumina at the time. And she said, this looks like cancer. All 12 of those women were diagnosed with cancer after they gave birth to their children. And so that really started the whole field of blood-based early detection, understanding that you could mine signals in the blood that were coming from abnormal DNA that were being shed from cancers when the cells were dying and then releasing their DNA into the blood. And so because of that, a new company at the time called Grail was formed. And I was fascinated with how you could use these approaches to develop them for early cancer detection. I've always felt like we'll make the biggest impact on cancer mortality through early detection and prevention. So I was really part of the original team that developed the field of in the space of multi-cancer early detection. I was at Grail for 4 years, and right now Grail is a company that has the first commercialized multi-cancer early detection test on the market. It's called Gallery. It can detect 20 plus cancers in the blood. And I am very excited about this opportunity and how it creates access for patients, through a simple blood test to detect multiple types of cancers. I left Grail and was really looking for different technology that I felt could really move the needle on the detection of early stage cancers. And so I met my colleagues a couple of years ago, and the technology that is Adela came out of the University of Toronto, and it's looking at methylation patterns that we can identify through a simple blood test in the plasma that can then give us signals for multiple different types of cancers, and not only whether cancer is present, but what's the underlying biology of the cancer. So I think that the field of liquid biopsy technology is moving not only to say, is disease there or not there, but what kind of disease is there? And that could really obviate the need to have tumor tissue in order to make a diagnosis and create a treatment plan for patients. So my vision of our company and our technology is that in 5-10 years, you will go to a doctor, get an annual blood test that will look for not only different types of cancers, but also cardiovascular disease, autoimmune disease, that we can use these technologies to detect and diagnose many different disease types.
Wow. Well, congratulations. And how exciting is that? I'm really intrigued by the work that you're doing. Let me ask you, how quickly can a blood test drive the understanding to drive drug development?
Yes. So liquid biopsy technologies are not only being used for early detection of cancer, but also to help expedite the treatment of different cancer types. So there is a whole emerging field, we call it cancer management, and we want to use blood tests in order to help us manage patients better. So if we take lung cancer, for example, what we are trying to do is understand which patients, when they have their lung cancer diagnosed and detected, after they have definitive surgery, which patients will benefit from additional therapy, and that can be done through a blood test. And we use, these technologies to say, is there presence of minimal residual disease in the blood? So these would be, pieces of DNA that we believe are derived from lung cancer that then tell us this person versus that person has a higher likelihood of relapsing from their lung cancer. And let's give them adjuvant therapy or immunotherapy that might really benefit them and give them a long-term remission. Additionally, therapies are being used, these blood tests are being used to select therapies. So can we identify patients through a blood test that are likely to respond to immunotherapy or not respond to immunotherapy? So, Julie, we just heard from Dr. Brahmer, Julie, that, immunotherapy is so exciting because it's really impacted a lot of patients and really, created, longer survival times for lung cancer, but a lot of patients don't respond to these therapies and they're very costly. So we want to understand through a blood test, how likely is somebody to respond? And when they're on this therapy, are they actually responding or not? And all of these liquid biopsy technologies, our methylome platform, as well as others, are being developed so we can do just that, affect the clinical decision-making across the cancer care continuum in a very personalized and precise way.
Fantastic. Thank you for all that you're doing. It's very exciting. Now I'd like to turn to Melanie Nallicheri, CEO of EQRx, who's developing new medicines with the goal of expanding global access for patients starting in oncology and immunology. And Melanie, I know that you just came back from Europe. You must be jet lagged and exhausted. But tell us a little bit, first of all, about why you feel so strongly about access to all these medicines for all of us. Equal access, I should say.
Equal access, yes. First of all, it's such a pleasure to be here and to be on this really wonderful panel. And a lot of what my fellow panelists have just talked about really is important to me. And part of the background that led to the founding of EQRx, Carolee, one of the wonderful things today is everything that we just heard about. I've been in the industry for close to 30 years. our ability to detect disease today, to actually leverage the genomic information to help develop new cancer medicines, the ability to really leverage our own body by way of immunotherapy to actually fight the disease, it has never been better. And I think we all have heard the terms, we live in the golden age of biology or in the golden age of medicine. That's wonderful. But if patients can't get access to that innovation, it's not going to help them. And if you look at statistics, Carolee, the unfortunate truth is that women are much more likely to face access issues than men. So if you look at some of the recent work that has been done, for instance, by the Kaiser Family Foundation, you see that a higher share of women forego healthcare services due to cost compared to men, whether that is that they're delaying care, to the points that my fellow panelists have just made. If you don't diagnose the disease early enough, it just becomes so much more difficult to treat lung cancer. We all know what the statistics say about stage 3 or stage 4 lung cancer versus being able to find the cancer earlier. But many of these women, more women than men, delay care. More women than men put off preventive services. More women than men skip doses or don't fill their first script. So if a woman ends up not, getting access to the innovation that we have to offer, we can change the outcomes for them. So we created EQRX with the focus of, and a mission to improve health for all through great, innovative, but affordable medicines. And so within the short 3 years that we have existed, we've put together a portfolio of actually immunotherapy. So we have checkpoint inhibitors in our portfolio. We have innovative medicines. We have a 3rd generation EGFR inhibitor for lung cancer. Those are important in the treatment of cancer, as we have just heard. But what's important is for us to be working with payers, with health systems, so that they expand access. And that means expanding access to all of those populations that may be underrepresented in clinical research, that may be expanding access to those that may actually hesitate or forego research. And so by partnering with them, what we're saying is, we're going to bring you these innovative medicines. We're going to bring you a checkpoint inhibitor. We are going to bring for lung cancer. We have the research to support how effective our medicine could be in stage 3 and stage 4 lung cancer. You, the payer in the health system, you do your part, and you ensure that the out-of-pocket burden on the patient is lowered. You make sure that it becomes easier from an administrative point of view for physicians to prescribe those medicines. And so you can make sure that equitable access, equal access, and equitable pricing can become a true reality.
Fantastic, and congratulations to you on all that you've done. You had said to me a little earlier that you've done a raise, or tell me how much you've raised to get your company going.
So in total, since the inception of the company, we raised over $2 billion because in order to do what we are trying to do, this is a problem that's a global problem. It's not just a problem in the United States. And in fact, as I think all of us here on the panel know, in certain countries, it gets even worse than the statistics that I just quoted, because women have an even harder time to really have their voices heard. And the problem of access is really not confined to the United States. It's not confined to Western countries. It's a problem everywhere. And so in order to really solve this problem that I just described, we believed that we needed to have more than one innovative medicine in our portfolio. We needed to have multiple options available to solve some of the both highest cost areas that we know and indications, but also those where we have the most innovative both diagnostics and therapies at our disposal. And so in order to do that and to do it on a global basis, we needed to create a very different company in a very short period of time. And so scale was important to us, and hence we raised the amount of money we did.
Fantastic. I mean, highly significant number, and obviously a very lofty group of goals and objectives. So we certainly appreciate all the work that all of you are doing. So I think I'd like to open it at this point to all of us having a bit of a discussion. And I have some questions that I'd like to just throw out, and each of you are certainly able to answer, or one of you can take it. But one of my questions that I think about often is, why are there such vast sex and gender disparities in lung cancer research funding and knowledge? Why do none of us, I never knew, for example, that lung cancer was the #1 cancer killer of women. We think about breast cancer, which is 1 in 21, I believe. Why don't we know this information? Why is there so little out there? Laurie, you might start with this, since that is, I think one of the goals of your organization is to create much greater awareness of and research in this topic. So I pass it to you.
Yeah, Carolee, thank you so much. And I can literally say this in one word: stigma. Sadly, lung cancer has had attached to it a terrible stigma that in essence is a blame the victim for their situation. And in many instances, it's thought, oh, you must have smoked, so you brought it on yourself. And in that context, it has been a very hidden disease. It's one that is rarely talked about. Obviously, with the survival rates so low for so many years, we haven't really had an army of voices that could turn around and advocate and elevate awareness in the way other diseases have been able to. So that's what we're really trying to do, is address this stigma head on. No one deserves lung cancer. It is a disease that should be approached with the same strategies for any other illness: prevention, earlier detection, and improved treatment options across the board. So that really has much to do with the state that we find ourselves in. But as we like to say, it's been our collective work that has worked hard to change that story and attack the stigma, and frankly, infuse hopefulness that does exist for our community through the earlier intervention opportunities, through screening and the research that you've just heard about from colleagues on this panel, as well as accelerated therapies, as well as immunotherapies that can extend not just quality of life, but survivorship. So it's about changing the vernacular around a disease that no one deserves to die from.
Yeah, no, well, of course, obviously, WHAM echoes all of that and supports the work that you're doing, and wants to amplify, obviously, and enlarge the messaging that we all need to have and be listening to. We have a question from part of our audience, which is, what can be done to address the disparity we see in funding and research for lung cancer in women? I don't know who might want to take that.
Well,
I don't want to dominate, but we just need to infuse greater federal research funding, and that is through advocacy that would pass what in essence is legislation that would increase that investment. That we know, if we learned more about the unique impact on women, it would certainly benefit men as well. But Julie, chime in.
No, I agree. The advocacy that has occurred has improved, but there's so much more to go for. When folks ask about or are trying to get funding for women's related cancers, lung cancer is not typically on the list. So that has to change as well. So I think that, through advocacy, all the way from the physicians to our patients and our groups, in order to go straight to Congress and improve really awareness across the board.
I think this was one of the reasons that we created the WHAM report, and obviously one of the reasons that we're trying to, that we were thrilled that Jan Schakowsky and Tammy Duckworth submitted the resolution that they did, which was to double the budget for the 4 areas of study that WHAM studied from 175 million to 350 million, which brings us to the 14 billion. We're hoping, obviously, that resolution will get funded. That would be a good start. Anne-Renee, I know you had your hand up.
I was just curious on Laurie's and Julie's and the panel's perspective on whether or not you think patients that are, eligible for screening, really, if there's enough education or awareness around the fact that, finding cancers at early stages through screening is not a death sentence, and actually, the cure rate is very high. I think when people think about lung cancer, they think this is a death sentence, this is terrible. Maybe I don't want to know it all if I have this, but really driving that education and awareness around early detection can, lead to, a cure for this disease.
Yeah. Anne-Renee, I'll start, Julie chime in, Melanie, of course, but at the end of the day, and it's a sad commentary, is that we had one of the most significant mortality benefits proven in clinical trial work for lung cancer.
Yep.
If it was any other cancer, you would have seen a national effort launched almost immediately to bring about national awareness, to see increased focus on reaching those who are at risk with the information, developing a public health delivery systems that would support the access to the preventive service. And again, the nature of this disease and the stigma, we still don't have a national awareness campaign that you would have seen driven by government, in other circumstances. So part of legislation that we have around women and lung cancer is to do just that. It's obviously calling on our NCI and our public health agencies to come together with a better and more robust strategic research plan that would help us fill those research gaps. It's increasing the access to preventive services, and it is increasing public awareness about the life-saving benefit that exists for thousands of people today. That's what we have been calling on administrations and Congress to do, and that's make lung cancer a national public health priority, because we have the opportunity to reduce cancer's mortality in the most significant way, because we could address what is the leading cause of death, more than breast, prostate, colon, liver, and many other cancers combined. So you could get me talking about this all day long.
Well
So I don't want to dominate. Julie, chime in. Melanie, add some.
No, I think Melanie had a comment. She's muted.
I was going to build on Laura's comments, which are, and the first stepping stone is to remember that gender is actually a really important criteria when we're talking about diversity and inclusivity. We tend to have a very single-minded way to think about diversity and inclusivity, and thinking about women as a group that we need to be inclusive of. And I think, Carolee, you said it in your opening remarks, in the clinical research. I mean, that, if we had more of the clinical research, we could talk more about it. That leads to more awareness. More awareness leads to, Laurie, what you just said, right? The removing the stigma and actually pointing a path to hope, that if you get diagnosed earlier, then there is a much greater chance of you to beating your cancer. I think Anne-Renee just said it. We really want to make sure that those women understand that there is a real chance at survival here. But for that, I mean, these are often mutually reinforcing things that we need to do. And I think making it clear that including greater proportions of women in the clinical research we do, and then highlighting that research, creating that awareness, I think that's really important.
Totally. I think we're all singing the same song, which is good. We just have to sing much louder somehow. One of the questions is, since we know women have a different way of responding to inhaled particles than men, what is your guidance for secondhand smoke? And is there anything known about that, Julie, or other, I guess, toxins?
Yeah, I think from secondhand smoke, so smokers are probably at the highest risk, and then it's exposure to secondhand smoke. So, we know that the flight attendants that were exposed to secondhand smoke back when smoking was allowed in airplanes did increase their risk for developing smoking-related cancers. And the same with workers in environments like that. So knowing that is very helpful. And again, someone who presents with symptoms that a cough doesn't go away, regardless of smoking status, it's important to know that lung cancer can occur. Other exposures would be long-term radon exposures. A lot of us live in areas where radon mitigation or evaluation is important to do. Obviously, spending the majority of your time in your home with high radon, particularly if you do a lot of work in your basement, that's important to know and important to mitigate. So I think knowing your risks of developing lung cancer, but anyone with lungs can develop lung cancer, and so that's important to be aware.
And Julie, I just curious, I mean, we're living in an age with climate change. I live out in California. We have, many days of the year now where, wood smoke is high, that, there's many pollutants in the air, and people are frankly worried about going outside and exercising. I mean, how do you view that being incorporated and folding into risk assessment as we move forward?
It is important to fold that into a colleague of ours, Dr. Swanton from the UK, presented data on environmental pollution and its association with lung cancer development. And so more study on that across the board is important to look at. And again, trying to develop models of risk so that we can better target our screening for these patients.
Anne-Renee, this is a very specific question to you, which is, how does Adela's methylome platform compare to the GRAIL platform in terms of cancer detection, sensitivity, specificity, and classification? And where is Adela in terms of clinical trials, and what have been the results thus far? Are there certain types of cancer that will be less or not detectable by the platform? Very specific.
Yes. So our platform is very different. So GRAIL uses an approach called bisulfite sequencing, which is a way to derive methylation signals from the genome, and that requires a chemical reaction. And in that chemical reaction, a lot of the starting material that's present in the blood gets degraded. So remember, when we're doing cancer detection in the blood, we're looking for a needle in the haystack. So if you start out removing some of that needle, then it's going to be harder to detect. We have a different platform that looks at the whole methylome. We don't create a targeted panel, and we don't have any chemical conversion or enzymatic conversion. And we have the same assay every time. So when we take somebody's blood, we run the same assay every single time. We're pulling down the entire methylome that sits in the plasma. So it's a very different technology platform. It's looking at methylation, but we believe we have a lot of significant advantages. Our platform has about 18 publications on it to date, and the company only was created last March. So we're still a little bit, early in development, and we'll be presenting data next year at national conferences. But it will be, we don't have a product out on the market like GRAIL. So we're in essence, working towards that and are making great progress, and very excited about the potential of our platform and the data that supports it to detect early stage cancers, stage 1 and 2, and to detect many different kinds of cancers ones that are inherently more difficult to detect. I know we're not talking about prostate and renal, endometrial cancer. These are cancers that affect men and women. But these are cancers that others have had a difficult time detecting, where we have shown that we can detect these with high accuracy.
Fantastic. What efforts are being made to get insurance companies on board to fund screening? And then how do we get primary care physicians, including OBGYNs, to encourage this type of screening? Is there enough advocacy within the medical community to develop this kind of screening? Melanie, do you want to maybe take that one?
Yeah, and I, of course, invite my fellow panelists to this. Having actually been in my pre-EQRX life in the screening arena as well, I absolutely understand what Anne-Renee was just referring to. It is not easy to get reimbursement approved, and I'm speaking here again globally and not just about the US. But it's of course fundamental. One of the core issues that we have encountered is that when you screen more people, you find more things, which is exactly the point. We want to find the cancer early. But of course, if it's found earlier, then it usually brings with it greater costs, because then you also need to treat people. And hence, again, the EQRX solution to say, okay, well, if the therapeutic is really excellent at treating the disease and comes in at a responsible cost, then the screening should be a no-brainer, right? And so I feel like in many ways, we are sort of the two sides of the coin that you really need in order to change the ecosystem for the better. And I can tell you, at least from our partnerships with payers, I often, of course, talk about the fact that you do need to make sure that the diagnostic is there, because otherwise you end up actually incurring greater costs. And I think slowly we're seeing sort of a change in attitude, but I would say, sort of harking back to my foundation medicine days, screening is still not where it needs to be. And it's certainly better in the United States and in certain Western countries, but it's certainly not where it needs to be when you look at countries globally. And so all the efforts that we just talked about, they need to be continued to be pushed. And I also agree with the whole idea of both stigma and as well as fear of knowing. We need to overcome that. And that's really, really important. But I think often what we find is it's the therapeutic follow-on costs that have the significant impact on the lack of desire of screening on the part of payers, and we can change that.
I also would add, if I may, that I think we have screening studies are very difficult to do. And they usually countries do them because they need to be so large. And I really think we need to advocate for intermediate endpoints in clinical studies that allow us to get screening technologies and tests approved earlier that will get reimbursed, very similar to the way drugs are approved, while we wait for the, what's considered the gold standard mortality endpoints. I think that is a conversation that's happening now in many different consortiums for cancer screening. We can't wait 10, 15 years, for studies to read out, so we can learn whether very promising and innovative technologies are going to affect mortality. We have to have earlier readouts that will enable us to get these technologies out there while we're waiting for some of the data that eventually will come.
If I can just add to Anne-Marie, and I'll be quick here, Carolee. Ditto, Anne-Renee, with what you were just saying. But with regard to the payers, the good news about lung cancer screening is that because it showed such significant benefit and had such a high preventive service acknowledgement of that, there are no cost shares or copays, certainly if you fit the risk profile. So it isn't an issue of whether payers should or shouldn't. It is a given. It is of such significance that it is a covered benefit. With regard to primary care doctors, they've been slow to the table, and I'm being very blunt about it. And it's very unfortunate. And I understand that they are the entry point for general good health generally. But we have a leading cause of cancer death that has a screening benefit that can save tens of thousands of lives. And they needed to get on board early and embed that in their practices of making sure that if there was an opportunity to share this information for someone who fit a risk profile, that they were informed and then directed to a place where screening and treatment was being done well and right. So they've been slow to the table. But the good news on the payer side is that screening in this instance, and we're working on that through multi-cancer early detection and screening tests, Anne-Renee, as you've described, to expedite, the approvals of testing and treatments, quicker. But we do have the benefit of no cost, no copays or cost sharing for screening for lung cancer if you fit that risk profile.
This is Julie. I think also just trying to make it easier for these physicians to actually do and document the reasons why they're ordering that test. Folks in the radiology community are advocating for, particularly for women, if the mammogram screening flag comes up on your electronic medical record, it should be easy to attach a CT scan flag for lung cancer screening. So something to potentially pair with other screening that's already being occurring. Again, that's something for us to advocate in the electronic medical record. Again, making it easy for physicians to order is the key, and making sure that patients are aware of this is also key.
That kind of leads me to the last question that I'm going to ask from the audience, which is there a model of a multi-sector effort to connect awareness to protection, detection, treatment of a disease that you would like to see happen for lung cancer? In other words, is there a roadmap to follow? Julie, do you want to start? And we'll go through each of us.
I think, just what comes to mind just from a cancer standpoint is breast cancer. What occurred early on in that cancer disease through advocacy is something. But I think lung cancer has kind of leapfrogged that on the flip side from a treatment and personalization standpoint. So I think we're working a little bit backwards in the fact that screening could cure more patients than just the therapies that have been developed for lung cancer. But again, from a cancer standpoint. But Laurie, your thoughts?
Yeah, it's such a wonderful question. And I think the way that we've approached it is that we know that the vast majority of people get their care in their communities. Over 80% access healthcare in community settings, which is why the focus has really been, how do you stand up high quality screening and treatment access in community hospitals and building the network out from that. And that was something that has been our roadmap, our framework from day one when the mortality benefit was proven so significantly in the trial. It's working with providers in the community to provide life-saving screening and care close to home. So I would argue that the roadmap has been that the access issue, certainly that Melanie touched on earlier, access where you can receive it close to home, and then continuing to listen to the people and patients about where their barriers and gaps are, and then advocating to address that so that we can shape healthcare delivery systems to benefit our patients and those at risk. So it's creating, I would say, community-based roadmaps and frameworks that can frankly get the job better than starting from top down. We're building it from the ground up.
And I'll just add to that I was on the board of the Breast Cancer Research Foundation from the day it started until for about 25 years. So I do appreciate very much the marketing savvy and brilliance of that team of people and the Lauder family that really brought such attention and awareness, a lot of it through its department store distribution. And so it touched the lives of all women, and in a way that I think I've never seen before or again. And so I do think if we look for a roadmap or a model, that certainly is one. And as you said, Julie, maybe we're further ahead in some of the medical technology or modalities of treatments, but we're not as far ahead, and it might be the inverse in terms of our ability to market properly. So we don't have very much time left, and I would like to offer each of you my magic wand and have you tell me, if you had a magic wand, what would you want to change now, and how would you see improving the lives of women through greater research, specifically in lung cancer? Laurie, do you want to just start off with that?
Sure, and we talked about this earlier. It really is about transforming survivorship, making sure that any woman who could be at risk for this disease has access to life-saving care that can improve their quality of life and save their life. That would be my magic wand, saving lives.
Anne-Renee?
Well, I'm with Laurie, but I would add as a initial step that we work very collaboratively with government and policy to make sure that women have access to to screening, and that we can expedite blood-based screening so we can reach more people that need early detection.
Julie?
Well, I think from my standpoint, in addition to what our other panelists have said, would be being able to personalize the therapy for each patient appropriately. We have a lot of technology as well as great treatments, obviously, that have to be improved, but be able to say, as soon as that patient walks into my office, this is the best treatment for you, and this is why, would be perfect. So I'll take that magic wand. So
That's terrific. And I'll ask the question again, how can we have personalized medicine if we're not studying women, which is basically
Exactly
what you're talking about. Melanie?
I mean, I agree with Laurie. Our first goal, of course, should be to extend survivorship. But for those who are diagnosed, it shouldn't matter where you are, what your socioeconomic status is. If that you happen to have been born a woman, you should have access to the best that innovation has to offer.
Well, bravo to that and to your vision. And thanks to all of you, our wonderful panelists. And again, to the GoTo Foundation. Laurie, it has been such a pleasure, and I'm so looking forward to continuing to drive this forward. And I thank you so much for your support. I would encourage anyone to visit whamnow.org or the whamreport.org, and you can find much more data and information. And I'll share with you that we feel very strongly that the only way that we will all create sustainable change is through collaboration in the ecosystem with all the players who can contribute to the well-being of society. I think you've heard everyone refer to that, and I think it is the magic potion that we all need to focus on. Our partners at WHAM are the leaders in each of their fields, and we bring together policy, advocacy, business, academia, and science to create a new platform and a new dialogue. And basically, we hope to ensure health equity, and I hope you'll all join us. Thank you so much for all of your contributions, my wonderful panel, and to all of you who came to listen to us today. I look forward to seeing you again very soon.
Thank you.
Thank you, Carolee.
Oh, my pleasure. Bye.
Bye-bye.